Hello and welcome to the Alabama Public Health Training Network. Thank you for joining us for today's program, 2016 Blood Pressure Control for Better Health. If you have questions about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are available online. You will need to register for this program in order to access these materials. Continuing education credit has been approved for today's program for nurses and social workers as well as nurse practitioners. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, continuing education credit will only be awarded for 1 year for nurses, expiring on March 31st, 2017, and 2 years for social workers, expiring on March 31st, 2018. I'm Dr. Jim McVeigh, Director of Health Promotion and Chronic Disease with the Alabama Department of Public Health, and I would like to welcome you and our faculty presenters today. Dr. Keelis Quells with the Harris School of Pharmacy at Auburn University and part of the Wellness Center for the state employees. Dr. Dina Maxwell, Physician Consultant with the Family Health Services, and Peggy Harrison, Manager and Parish Nurse Program with East Alabama Medical Center. Welcome to everyone and thank you for joining us. Now we begin our program with Dr. Maxwell's presentation.
Thank you. Good afternoon. Thank you all for joining us today. We're going to be talking about something that's very relevant to all of us sitting in this room. If you're not diagnosed with high blood pressure, chances are you know 1, 2, 3 different individuals who are diagnosed with high blood pressure. And so what we want to talk about today is how we can have a standardized approach to identifying those persons at risk, identifying those persons with the disease, and getting them to a treatment goal. One of the things that we'll talk about is this needs to happen in a different relationship from what we've done historically, where it's been the provider and the patient. We want to go to a broader approach and include other entities. So we have several objectives. I won't read all of them to you, but what we want to do today is make the case that hypertension is a significant risk factor for cardiovascular disease. It is a very treatable condition and one in which we can make better gains than we have. We want to identify and reiterate some of the direct complications of having elevated blood pressure that's not controlled. And we want to talk about the need to get more people who have high blood pressure to goal. In addition, we want to discuss some of the things being done here within the Alabama Department of Public Health and within the community setting to increase awareness and increase effective treatment and identify different strategies to improve our health outcomes as relates to high blood pressure. So why do we care about this? This estimated that 80 million Americans have high blood pressure. And as we move through the talk, we'll see that although 80 million Americans are known to have disease, far fewer Americans are at goal with regards to treatment. It's expensive. In 2011, estimated costs were $46 billion. In 2030, it's estimated that this is going to go up to 274. And this affects all of us, even if you don't have hypertension. When these healthcare costs escalate, then the costs are redistributed amongst all of us that are involved in these healthcare plans. Another reason that we need to be concerned about this is that in a 10-year time span from 2001 to 2011, our deaths attributable to high blood pressure increased by 13%. So in discussing this, let's briefly go over some key facts or attributes of blood pressure. We know what it is, we hear about it all of the time, but what does it mean? When we talk about blood pressure, it is the force of blood as it flows through the artery walls. It is the most common condition seen in primary care. Of my office visits on a daily basis, about half of them are follow-up high blood pressure diabetes. Interestingly enough, we see a lot of people who come in for a headache or knee pain and their blood pressure is elevated. Some of these people have had a diagnosis of hypertension before. Others have no idea that they have hypertension. So when we say it's one of the most common conditions, it's seen as far as appointments, but we also diagnose a lot of people at the point of care. It can affect just about every organ system in your body. And most importantly, it is probably the single most reversible risk factor for cardiovascular disease. When we talk about high blood pressure, when we treat it, it's helpful to think about it as stage 1 and stage 2. The most recent guidelines simply state that it's blood pressure greater than 140 over 90 with a specific goal for treatment. So in 2009, more than 37% of Alabamians reported having high blood pressure. Now, the population of our state is roughly 4.9 million, and so 37% comes out to about 181,000 people. If you consider that the population of Montgomery is somewhere around 200,000, minus 20,000, that's how many people in our state are walking around with high blood pressure. And as we'll realize as we move on, those people are not all at goal. Also, what I want to mention here briefly is the differentiation between systolic and diastolic. Many times in clinic, patients will come in and they'll say, oh, my bottom number is high, but it doesn't matter. It's my top number that matters. Both numbers are important. There are some different groups of thought in the medical community that maybe systolic blood pressure has more implications, but I would urge us to encourage our patients, our family members, that both numbers need to be at goal. Systolic blood pressure is the force with which your heart has to squeeze when it contracts. If those pressures are elevated, the heart is having to work, do more work to get the same job done. Different from that is diastolic blood pressure. Diastolic blood pressure is the pressure when your heart is at rest. Your heart is a muscle. Just like if you're an avid athlete or a trainer, when you work and exercise, you need a recovery period. So during diastole, that's when your heart rests. The other important thing about diastole is that this is when the heart is fed by the coronary arteries. So imagine again that everything in the body is, as it relates to the cardiovascular system, is a pressure system. If the heart is at rest and the pressures are elevated, it makes it that much harder for those coronary arteries to feed your heart. So both of those are important and something we need to keep in mind when we talk with patients. So when we look at Alabama as compared to the state, we have a higher number of adults reporting having hypertension. In 2011, the state of Alabama was at 40.1% compared to 30% for the nation. In 2013, we were again 40% while the nation was at 31%. Nationwide, the percentages are about the same. When we talk about people who have high blood pressure, we need to remember that just because you're diagnosed with high blood pressure does not mean your blood pressure is controlled. I'm sure many of you know people who take blood pressure medicine and every time they check their blood pressure it's still a little high. That person needs to be back into treatment working to get those numbers down. Nationwide, about 45% of the people diagnosed with high blood pressure are not at goal. And that comes out to about 36.7 million people. So one of the overachieving goals of programs like this is that we want to move people towards control. The American Heart Association has identified a goal to get 13.6 million people to control by the year 2020. 13.6 is still only a fraction of the number of people nationwide not at control, but if we consider 13.6 less strokes, less heart attacks, less chronic kidney disease, then certainly that is a broad goal and one we need to work towards. So I've said a lot that we have people who are identified with high blood pressure, but they are not at goal. This is what this chart shows us. 81% of people are aware, the Green is 2011 to 2012, and the blue is 2009 to 2010, so just two different time frames. But the numbers are about the same. About 81% of people are aware that their blood pressure is not where it should be. Of that 80%, about 75% actually start treatment. Of that 70%, then only 50% of those patients have a blood pressure of less than 140/90. And so certainly we need this graph to trend in a different direction. So what causes high blood pressure? As of right now, there's no single cause of high blood pressure. We know that there's a strong genetic component. If your mother had high blood pressure, your grandmother, your sister, your aunt, the likelihood is that you too will develop high blood pressure. There are a lot of associations as it relates to blood pressure: insulin resistance, obesity, excessive alcohol intake. Others that we know about: high salt intake, getting older. Sometimes blood pressure will change and become higher just because of the natural changes that happen in our arteries as we age. Not being active, stress will contribute to blood pressure. And then these others, low potassium and low calcium intake, those are important because one of the lifestyle modifications looks to directly address that. So let's look a little bit at our blood vessel. What we do know is that hypertension increases the risk of atherosclerosis, or hardening of the arteries with plaque formation. If you look at this image, you can see that on the side where there's normal blood pressure, you have a nice open lumen. Blood can flow, it's unobstructed, things are fine. As you move over to pre-hypertension, what you can appreciate is that the diameter has gotten a little bit smaller. This is where we could really make differences with lifestyle intervention. Now, as you progress over to hypertension, at the far end of the slide, look at that small area with which blood has to be forced through. There are several implications from this. What basically happens is there's some remodeling that takes place. This can cause the artery to become hard and less elastic. This can cause that diameter to become small. You get plaque formation, you get an inflammatory response, all of which lead to the development of cardiovascular disease. This remodeling is detrimental to the artery itself, and we have certain medications that help to combat this remodeling. But this is a simplified way to think about how high blood pressure affects your arteries. Patients whose blood pressure is elevated, greater than 140/90, will often become patients who are treated for serious heart conditions. We know that this is a cumulative effect, and so the longer someone's blood pressure is elevated, the more damage it is doing internally. We know that if we can reduce your blood pressure by 20 millimeters, that you'll have a 4-fold decrease in mortality from hypertensive heart disease, a 2-fold decrease from congestive heart failure, aortic aneurysm, atherosclerosis, and sudden death. That's just with a 20 millimeter decrease. You know, a lot of times we'll see patients whose blood pressures are 180/90 and they want it to be fixed tomorrow. It didn't happen overnight, and we're going to get you to go over time. But even when that patient comes back in and we've gotten them to 160, you have already decreased their risk for sudden death. Consequences of high blood pressure. The cardiovascular outcomes that are attributable to high blood pressure are numerous. The studies are consistent, and it's just a proven fact that high blood pressure predisposes you to problems in all of these areas. Stroke, heart failure, two types of heart failure. One type of heart failure is systolic, where your heart does not squeeze or pump. The other goes back to diastolic heart failure, which is a different entity, but it's heart failure all the same. Most people are familiar with the heart failure of the systolic heart failure, but don't realize that diastolic heart failure is an issue too. Erectile dysfunction, big problem that can happen with elevated blood pressure because vessels in every part of your body are affected. heart attack, and then kidney disease or kidney failure. Again, cumulative effects. If we can identify you early and correct your blood pressure, we can certainly slow the progression to chronic kidney disease or decrease your risk for these other outcomes. So let's talk specifically about cardiovascular disease and hypertension. High blood pressure is the largest contributing factor to all causes of cardiovascular death and disease, period. If we can affect this one outcome, we could affect so many different problems and issues within our population, within our patients, within our own family members. The proportion of mortality attributable to blood pressure alone is 40% from this one disease entity. In 2010, it was listed as the primary or contributing cause of death for more than 360,000 Americans. When we look at the state of Alabama, again, 40% of Alabamians have been told that they have high blood pressure. The estimated morbidity for adults over 20 is 32.5%. So on this handout, and it may show better on your actual handouts, this is just a grouping by public health area to show what the percentages of hypertension are. A lot of times we hear a lot about the Black Belt region of Alabama having poor health outcomes, but what I personally found interesting was that around the state as a whole, we're running 35 to 45% of people having blood pressure in different public health areas. So this is one that we see distributed statewide. It's not just associated with some of the socioeconomic concerns in the Black Belt. We're seeing this across all areas of the state. When we look at the causes of death in 2013, the number one cause of death was heart disease. Stroke was the fourth leading cause of death, and primary hypertension was number 12. So the question becomes, why aren't we doing better? We're at a time in medicine and healthcare where technology is at the peak. We know more about the pathophysiology of disease. We have more medicines than we've ever had to treat high blood pressure. Why then do we only have about half of our patients at goal? There's a thought that we need to change how we deliver care as it relates to high blood pressure. We need to take that care just from the provider-patient relationship and expand it to other entities in the community to get the message out and to help people move towards goal. So we need a more multifaceted approach. You have your providers, be it your nurses, nurse practitioners, physicians. You have the patients. You have the patient's families. A lot of times what the patient is able to do is a direct result of what's going on in the home. You have communities, you have your local nurses, you have your local pharmacies, and then you have your healthcare delivery system. And one of the issues there has been access. And so if we kind of decentralize this approach, we take the care to where the patients are in the community. There are a lot of different agencies that have realized, okay, we need to do something. We know how to treat high blood pressure. We know how to diagnose it, but why are we not getting people to go? So there are departments within the Department of Public Health. Chronic Disease and Health Promotion is one. There's the American Medical Association. There's an organization, Million Hearts, which is a nationwide initiative to improve stroke outcomes. The American Heart Association has a program, Check, Change, Control, that is looking to move that 13.6 million people to goal. And then we also have within the Department of Public Health the Cardiovascular Health Program. In talking about trying to reverse this trend, we want to talk about increasing awareness, early detection and diagnosis, a systemic approach to treatment, and treating people to goal blood pressures. So within our Department of Public Health, we have several agencies that are working to do this. Chronic Disease and Health Promotion is one of them. They're putting on the program that we're participating in today. They've worked to provide community outreach programs, community monitoring programs to help engage patients in their own health care and to be more proactive. The Cardiovascular Health Program is another entity within the Department of Public Health, specifically looking at cardiovascular outcomes, heart disease, and stroke. Within the Cardiovascular Health program, we have the Alabama Blood Pressure Task Force Work Group. This organization works to come up with guidance on best practices as it relates to achieving blood pressure goals. The Blood Pressure Task Force has educational programs on reaching blood pressure control through evidence-based programs. There's a blood pressure toolkit that we'll revisit a little bit later. But what they really have worked on within the last year or so is developing an approach to, a standardized approach to tackling blood pressure, a blood pressure algorithm. And we'll come to that a little bit later in the presentation. The next facet of trying to improve our blood pressure outcomes is early detection. Blood pressure measurement is easy to do, it's inexpensive, it can be done just about anywhere, yet and still we have an epidemic of hypertension. When we talk about screening, does my age matter? Yes, there are different criteria for pediatrics, and so we're speaking today mostly about adult patients. How often should I get screened? What tests do I need? You need a blood pressure cuff and a chair and someone who can measure your blood pressure. If it's an automated machine, you don't even need a second person. You just press the button. Screening can happen anywhere. Most of your doctor's visits, you'll have your vitals taken each visit. My first day as a medical student, my attending said vitals are vital, and I'm sure some of you have heard that. And blood pressure is truly vital. If the patient who normally is very well controlled is elevated, then something else is going on. Likewise, if a patient who is never at goal comes in and their blood pressure is low, that can clue you into something else that may be going on with the patient. So most doctor visits, you'll have blood pressure taken. Home monitors. There are a plethora of home monitors available. They're not very expensive, and they give us good information because we get better readings when patients test consistently at home as opposed to that one-time snapshot we get when they come into the office. Local pharmacies, they have automated machines. Some of your local pharmacies even have techs and people who will do a manual blood pressure for you. The good thing about the pharmacy is you can stop and ask, well, what does this mean? And your pharmacist can give you some information or say, you need to talk to your doctor because this medicine may not be helping you. Community screening activities, any church function, school function, you have a blood pressure cuff, that's an opportunity to screen for blood pressure. Health fairs, and then in my community, local fire departments will check your blood pressure. So this just reiterates that of the 76.5% people treated for blood pressure, only about half of those are at goal. But the other caveat to this slide is that we still have 17% of people who have not been formally diagnosed with high blood pressure. So when we talk about early detection, we need to make sure that we are getting an accurate blood pressure reading. This is one of those things that you do it so often, you do it without paying attention, and you probably forget that there is a little bit of technique associated with taking a blood pressure. We probably don't do it quite right in your physician's office because you come from the waiting room and then you sit down and talk to the nurse and then you go to another room and we've checked your blood pressure in the midst of all of that. In an ideal world, we'd be able to have you sit for a few minutes and then check your blood pressure. Sometimes in private practice, if patients come in and you can just tell they're flustered, I'll have them sit in the exam room and we'll talk about something else and then we'll recheck the blood pressure after they've been sitting for a few minutes. But when we talk about checking blood pressure, there are some things to remember. A is achieve a calm state. B, body posture is important. You should be seated in the chair, your back against the chair back, and your feet resting flatly on the ground. Sitting with your ankles crossed can affect your blood pressure. This isn't really body posture, but it's worth mentioning. Having a full bladder will affect your blood pressure. And so those are things that we need to help train our staff to think about if the blood pressure reading doesn't match what the patient has normally run. Calibration of equipment is usually done before it gets to your store. You want to make sure that your equipment has been validated by an organization. And then again, D is double check any high reading. Ideally, we would like to check this at 2 separate visits, but this is not an ideal world, and so that usually doesn't happen. We usually wait about 5 to 10 minutes and repeat to verify. And at this point, we're going to watch a short video about proper blood pressure measurement.
Taking your blood pressure at home can help you control your levels and is simple to do. You should take readings at the same time each day, such as before you take your medications in the morning and before bedtime at night. Don't smoke, drink coffee, or exercise for at least 30 minutes before measuring. Sit comfortably in a chair with your back supported and rest quietly for 5 minutes. Keep your feet flat on the floor. Don't cross your legs. Using a table or desk, support your arm in front of you at about the level of your heart. Wrap the cuff snugly around your upper arm, just above the crease in your elbow, and inflate the cuff. Take 2 or 3 readings about a minute apart at each session. Record all your readings, along with the date and time of day, and bring this log with you to your next healthcare appointment.
I can see you were quite high when we first started here, about 150, and then
measuring your blood pressure each day will give your healthcare provider a clear picture of your blood pressure in your everyday life.
I can see that you're very well controlled.
Your medications may need to be adjusted to help you maintain a healthy lifestyle. The American Heart Association does not recommend any particular brand of blood pressure monitor, but there are some things to look for when you shop for a unit. Consider only those with an inflatable cuff that wraps around your upper arm. If your upper arm is larger than average, you may need a bigger cuff. Wrist monitors are not as accurate as cuff monitors. Look on the label to see that the monitor has been validated for accuracy and reliability. When you go for your next checkup, take your blood pressure monitor with you. Ask your healthcare provider to make sure you are using it correctly and test it for accuracy.
Okay, let's check your monitor now and see if you get the same readings as I got with the Mercury device.
It's a good idea to have your monitor tested each year.
Okay. So again, the video just kind of reiterated some of these A, B, C, Ds. You know, again, in a perfect world, you could sit and rest before you checked it. Even if you could just sit for 2 or 3 minutes, if you can't wait 30 full minutes. The other thing that I wanted to mention is I have seen some apps that say, let me back up. There is some technology coming out that will allow you to check your vitals through your smartphone. There are some out there now that is not very reliable. And so, you know, be mindful about what you use to check your blood pressure. Again, a good blood pressure cuff isn't extremely expensive. The fit of the blood pressure cuff is important. If the cuff is too small, your reading is going to be falsely elevated, possibly. Keeping a log is very helpful. A lot of times patients get very excited when the blood pressure is high and then they check it 30 minutes later and it was normal, and they check it an hour later. So your blood pressure will fluctuate. If you're angry, if you're excited, if you're happy, your numbers will be different. What we like to look for is the pattern of what your numbers have been doing. So if you could get in the habit of seeing over the course of 7 days, what is my blood pressure done, that information is helpful to your provider. So that's a little bit about early detection and diagnosis. What we want to talk about now is a systematic approach to treatment. So for those of us in the healthcare community, JNC8 was a long-awaited big deal. It was supposed to be. When I started medical school, I think we were on JNC7, and I can remember that JNC8 was supposed to come out in December of that year. I've been out of residency almost 4 years, and JNC8 just came out last year. What this is a joint national committee. This is a group of experts in the field of hypertension and cardiovascular disease that is convened to decide what are the best practices for blood pressure control and treatment. This is an expert panel, and their report was much anticipated. We've had different variations. Like I said, JNC7 was out for a long time, and there are some differences in what the recommendations have become. A lot of times when we're talking to patients about blood pressure, they can remember when normal blood pressure was 120/80. Well, one of the things that JNC8 has said is that the goal for blood pressure is anything less than 140/90, period. The other thing that JNC8 has said is that if you are over 60, we don't treat your blood pressure until it's higher than 150/90, which is a little bit different from what previous panels recommended. There was a bit of dissent with that notion that older people could tolerate a little bit higher blood pressure. And so in full disclosure, I want to mention there was a minority report by several members of this JNC8 panel that said we need to have similar blood pressure goals across all age groups. But the general consensus, blood pressure is considered elevated at 140, anything higher than 140/90. What JNC8 says is if you're over 60 and have no other health conditions, we don't need to treat you until your blood pressure is higher than 150/90. So this is just presented kind of as historical context for our talk today. The other thing that came from JNC8 was this idea that we needed to have a more standardized approach to blood pressure treatment. So the broad goal for this would be that if you were diagnosed in Florida or if you were diagnosed in Mississippi, that you would have the same medicine. If you were stage 1 hypertension, they'd see you back in some time frame. If your blood pressure wasn't better, you'd get the same recommendation whether you were in Florida or whether you were in Mississippi. What that approach developed into was an algorithm. This algorithm says that for certain categories of blood pressure, this is where we start treatment. It takes into account other comorbid conditions, specifically diabetes, heart disease, chronic kidney disease. And it also looks at race in making recommendations for medications. The algorithm also highlights lifestyle modification. We always preach to patients lifestyle, but what are they supposed to do with that when they go home? And so the algorithm does a pretty good job of identifying some, let me go back to the slide for just a minute, what the lifestyle modifications are. This is just a basic algorithm that I think this one may be American Heart Association. And so what this says is it gives you action steps at different points. It gives you in that panel different lifestyle modifications and what to do and what to tell patients. So when the American Heart Association came up with this, they said, well, we want people to follow basically the same steps, but we want to give them individuality and ability to modify. So now what we're going to look at is what the Blood Pressure Task Force came up with for the Alabama Hypertension Control Algorithm. And we're going to try to make this work. Okay, so before we look at the actual algorithm, and this is available on the website as well, what it talks about is things to consider. You know, if the blood pressure is elevated on that first attempt, remember, let the patient rest, relax, and repeat it. It talks about secondary causes of high blood pressure like white coat hypertension and looking at whether patients are compliant with medication. In the next box, it talks about special considerations. And so if people have had heart disease, there are certain medicines that we would consider first line for them. If they have had a stroke or TIA, what people often refer to as a mini stroke, you would use a diuretic or a medicine called an ACE inhibitor. The other interesting thing is that we have noticed now that there are some medicines that confer different levels of protection to African American patients as it relates to stroke outcomes. And so now we see that these are considerations as well. So looking at the algorithm itself, okay, so what we did with the algorithm for the state, we'll look at this box first. If they're over 60 and no other health conditions, specifically diabetes or kidney disease, and if their blood pressure is over 150/90, you go to your first box, and your first recommendation would be lifestyle modification, and you could consider medication at that point. If we move down, we see that then you recheck the blood pressure in 2 to 3 weeks if they were started on medication. Now, the time frames are important because sometimes we tend to titrate medicines too quickly. Sometimes we don't titrate them after more than enough time. But 2 to 3 weeks is given as a time frame because we want to see the effects of medication if it was started. If you said, well, this is a pretty motivated patient, I think they're going to get their blood pressure down without medication, the recommendation on this algorithm is they can come back in 3 to 4 months if you recommend it, if you prescribe lifestyle. You see the patient back. If their blood pressure is at goal, you continue what you're doing. If they're not at goal, you go down the next box. Same thing happens if we move back up, and if they're age less than 60 with comorbid conditions, but their blood pressure over 140/90, then you would move down this treatment box. So this is one example of how the task force modified the algorithm from the American Heart Association. And we're going to go back to the slides. So within the Department of Public Health, we also have begun or delved into hypertension management. The Wise Woman Screening Program is a national program which is funded by the CDC, and it takes low-income or underinsured or uninsured women and gives them an opportunity to participate in a comprehensive risk factor reduction program. The priority age group is 40 to 64 years, and the participants are screened for blood pressure, diabetes, obesity, and cholesterol. So as part of the Wise Woman program, what we decided to do was to allow the nurse practitioners in 2 health departments to begin blood pressure management programs. And so if they're in for their Wise Woman screening and they're identified as having high blood pressure, then they're referred to the nurse practitioner for treatment. And so again, we went to an algorithm. We looked at the American Heart algorithm, and we decided, well, how can we still stay in this framework but make this a standardized approach so our nurse practitioners in Shelby County and our nurse practitioners in Tuscaloosa were doing the same thing. The other reason we thought it would be helpful to use the algorithm is because we realized, well, you know, the nurse practitioners have been doing family planning, women's health. This was going to be a little bit different, and we wanted to make it as user-friendly as possible and less difficult for them to adopt it into what they were already doing. So this algorithm is a little bit different from the first one. What we do with our algorithm is we classify people as stage 1 or stage 2 hypertension. Stage 1 hypertension, you might consider that mild if their blood pressure is 140 to 59 on that systolic or 90 to 99. We classify those as stage 1. Now, if this patient who has what we'll say is mild hypertension has diabetes or if they have kidney disease, we might be a little more aggressive and treat them as a stage 2. But for the purposes of this discussion, we'll say that this is a fairly healthy individual who has had these elevated blood pressures. So what we do is give them a trial of lifestyle modification. Now, we're very fortunate with the Wise Woman program because we're able to really do lifestyle modification. They are able to meet with the nutritionist. In some of the programs, they get a gym membership. And so they really get to do those things that the nutritionist is telling them to do. There's health coaching. So somebody's calling and saying, well, hey, how's your blood pressure today? Did you go to the gym? What's going on with you? And so when we do the lifestyle modification as therapy, we have those patients come back in 3 months. If in 3 months the blood pressure is not at goal, then we look at starting on medication. And my mantra to the nurse practitioners is start low and go slow. That's not correct English, but it's catchy and they can remember that. And so that's what we tend to do. What we have given them are options for starting medications. And so after we start medication, we see the patient back in 4 to 6 weeks. And then again, if they're at control, we continue what we're doing and monitor them less frequently. If they're not at control, then we optimize whatever medicine we put them on the first time, or we add a second medication. So it still gives the nurse practitioners flexibility to choose which medicines they want to do, but it gives them a framework within which to operate. Stage 2 is the same process, but I will just show you that what's different on stage 2 is these patients get treatment the day of. And when I say treatment in this sense, medical treatment the day of the visit. And so the follow-up is similar. Go back to the slides. The last thing we want to talk about is treating patients to goal. Again, 1 in 3 Americans is living with high blood pressure. For every 10-point drop in your systolic blood pressure, we get a 30 to 50% risk in cardiovascular disease and stroke. This is to remind us that of the people diagnosed with hypertension, we have 36 million who are walking around with elevated blood pressures despite taking medication. So despite taking medication, they're still walking around with an increased risk for stroke, heart disease, or kidney disease. The goal, again, as set by the American Heart, is to move 13.6 million people to control. So this is a reminder of what our goals are. Again, if you're over 60 and in good health, we treat to a goal of less than 150 over 90. Everyone else needs to be treated to a blood pressure of less than 140 over 90. But a reminder that guidelines are meant to be just that, to serve as a guide. Individual treatment goals may be needed based on your family history of stroke, based on your activity level. I have had 75 and 80-year-olds who probably were some of the healthiest people I've ever met that I would feel needed to be treated to a tighter blood pressure goal. Likewise, you have patients that are frail, that are elderly. If you overtreat that blood pressure and they have a syncopal episode and fall and break a hip, then that's a detrimental outcome. So although we have these guidelines, it's very important to talk with your specific healthcare provider and say, where are my goals? Where does my blood pressure need to be? This involves the patients and the providers working together. Medicine historically has been very paternalistic. You do this because I say do it. That does not work anymore. You have to engage the patients and understand what are the barriers to them implementing the program that you've come up with. And so I encourage patients to ask questions, to have opinions, and so you can work with your patient to help them see what their best goal is. So in summary, I hope that we have seen that hypertension alone is a strong risk factor for cardiovascular disease, but it is a largely modifiable risk factor. There is no reason that we can't have better blood pressure control than we do as a state and as a nation. It's going to take us moving out of just the exam room into the community, involving other entities to get to goal. And hopefully, as we hear more and learn more about this algorithm, we'll begin to see more standardization of care across healthcare providers. And with that, I think we have a few minutes for questions.
And we do have 2 questions already in. Ken Reed, if you could tell us what questions we've received so far.
The first question is, can you tell us more about white coat syndrome, and if there's anything that can be done to ensure an accurate blood pressure reading is taken?
So white coat syndrome is difficult because patients are not always looking as if they're anxious. They don't look uncomfortable. The best thing to combat that is if you can get your patient to monitor blood pressure at home. Another avenue that we have available sometimes is a 24-hour blood pressure monitor. That is a very helpful tool. It's similar to a Holter monitor that most people are familiar with, but it cycles and measures your blood pressure about every 15 minutes. And so home monitoring and the use of a 24-hour blood pressure monitor would be 2 key things.
Do we have another question?
We do.
Ken?
The second question is, if someone has high blood pressure, are automatic blood pressure machines as reliable for tracking progress as taking it the old-fashioned way?
So that becomes dependent upon the user on the manual blood pressure. I still think that most of our nurses, staff, myself, if I am not certain that the machine is right, I will do a manual blood pressure in the clinic. Again, the manual blood pressure, the reliability is very much dependent on the operator. But for the most part, your automated machines are very precise and are very accurate. I would like to say a word about wrist cuffs. Not my first choice, but if that's the only thing the patient has, we encourage them to use it. It tends to give us a little higher reading, but the readings will kind of be consistent over time. So if it's high all the time, but then we notice that it's coming down, we can know that we're making some difference. But as I mentioned in the video, the wrist cuff monitors are not as accurate in some patients.
If that's all the questions we have so far for our presentation, we are going to take a 10-minute break now, and that will allow you to get a drink of water, and we will reconvene at 2:55, and we'll start back then. So thank you so much for your time. We look forward to the rest of our presenters. Welcome back this afternoon from our break, and Dr. Maxwell and I were talking during the break the importance of this program that we are having, the fact that we actually have about 1.8 million people in the state of Alabama with high blood pressure, which is hard to believe. But we will continue on with our next presenter on pharmacist's role in hypertension management. Dr. Quills.
Hi, my name is Dr. Camille Keelis, and I'm actually with the Auburn University Harrison School of Pharmacy. And like Dr. McVeigh had mentioned before, I actually work here in Montgomery at the State Wellness Center, so thank you for the introduction. So today I want to really talk about the pharmacist's role in hypertension management. And some of the objectives that I will be covering today is going to be the pharmacist's role in the collaborative healthcare team, pharmacist and medication management, disease education and medication counseling, improving medication adherence, and lifestyle management counseling. So to start, it is actually predicted that by the year 2025, more than 1.5 billion people worldwide will have hypertension. And that's going to account for up to 50% of heart disease risk as well as 75% of stroke risk. For several decades, it has been well known that lowering blood pressure with lifestyle modification, medications, or both of those techniques can substantially reduce a patient's subsequent risk for disease. For each 10 millimeter mercury decrease in systolic blood pressure, we can actually see the average risk of heart disease mortality decrease by 30% and the average stroke risk mortality decrease by 40%. And this was highlighted during Dr. Maxwell's presentation. However, despite the clear benefits of blood pressure control on reducing cardiovascular morbidity and mortality, only about half of those with hypertension have adequate blood pressure control. So what are some of the causes for this poor blood pressure control? And there are many of them. Lifestyle choices, including suboptimal patient medication adherence, as well as a failure to intensify therapy by clinicians, so also known as clinical inertia. And one of the most effective strategies to improve blood pressure control is team-based care, especially one that includes a pharmacist on that team. So I want to go over some types of collaborative care that is in practice today, and I'll go over two models. The first one is going to be the chronic care model, and this is actually going to be a collaborative partnership between patient, provider, and the care team. And basically, each is going to share in the decision-making process to help optimize that patient management of their chronic disease. This is also going to support the management of their chronic disease over multiple encounters and adjustments in their treatment plan to try to achieve that optimal care for this patient. The second model is going to be the patient-centered medical home. And basically, patient care is going to be organized around the needs of the patient, their relationship with their physician, and the physician-led teams form and reform based off of the patient's needs. So this is going to consist of the physician actually delegating responsibility to other care team members, and I'm going to highlight some of the responsibilities of the pharmacist within that care team. And so the pharmacist could be in charge of performing a medication history, identifying any problems and barriers to disease control, also counseling on lifestyle modifications, as well as making those adjustments to medications based on the current hypertension guidelines. What this is going to allow by delegating these responsibilities to others, the physician is going to be able to address more of the acute care problems as well as complications of other diseases and chronic care. So now I really want to focus on that pharmacist role, and I would like to reiterate that with pharmacists, we are the most easily accessible healthcare professional. As you know, we are located in many street corners at your local Walgreens and CVS, but we have other places of access, such as with myself at the State Wellness Center. And we have the necessary tools and knowledge to implement timely screening and effective prevention initiatives. And so we have this significant role in medication management of patients with hypertension. And this is not solely limited to just medication counseling. It's going to include designing, modifying, and optimizing medication regimens. This is also going to include simplifying or managing complex drug regimens. This is also going to have assessing their adherence to their medications and maybe providing strategies for improvement. Also recommending some cost-effective medications, as well as performing drug interaction reviews when we're getting these medications into our system to fill that prescription for that patient. We are also a good source of providing patient counseling since, again, we're that easily accessible healthcare professional, and typically the pharmacist is going to see that patient at a more routine, whether it's every 30 days or every 90 days compared to other healthcare professionals. And so what we can do for that patient is provide them disease education. We can also discuss the rationale of certain drug therapy choices with those patients. We can also educate them on the proper use and storage of the medication. We can also talk to the patients about expected side effects with those medications, especially when they're first starting their therapy. And we can also counsel them on appropriate lifestyle changes that they can make to manage their chronic disease. And so now I want to really talk about some of the evidence that we have regarding pharmacists' role in this collaborative care team. And I will say there is a plethora that is solely directed at hypertension management. And so the first study that I really wanted to kind of see here is actually a relatively early study. We were seeing some of the benefits of pharmacists involved in patient care as early as 1973. And this was actually done in community pharmacies where pharmacists actually evaluated medical records and made recommendations for changes in therapy at an urban health center in Detroit. And what they noticed with that simple study is that when they looked at the intervention group, blood pressure was significantly improved. And then after that intervention had ended, it was noted that blood pressure control actually deteriorated once it was discontinued. So we can definitely see that pharmacists can have some sort of impact into this patient care. Another study was something a little bit more recent. It was back in 2003, and it was a physician-pharmacist co-management of hypertension within an integrated healthcare system where patients attended a hypertension clinic run by pharmacists, and the pharmacists were able to make recommendations to the treatment plan. It was actually noted that systolic blood pressure was significantly reduced in the co-managed group compared to the usual care group. And the evaluators actually observed a little over a 20 millimeter mercury reduction at systolic blood pressure at each time point, which demonstrated some clinical significance. As we remember from Dr. Maxwell's presentation, a 20 millimeter mercury drop in blood pressure can significantly reduce that cardiovascular risk of mortality risk and morbidity risk. So another study, back in 2007, they decided to look at a whole wealth of studies out there and decided to do a meta-analysis of pharmacy-based interventions and found that the pharmacist interventions significantly reduced the systolic blood pressure while controls actually remain unchanged. And again, more recently, we see some more studies with pharmacists where they were able to make specific recommendations. And mainly this was in intensifying therapy to physicians and patients to improve blood pressure control in a 9-month study. And it was actually noted that blood pressure goal was achieved in 89% of the patients in the intervention group, while only 53% of the patients achieved goal in the control group. And the intervention actually had some long-lasting effects at 27 months of the study, which was actually 18 months after the study had ended. Blood pressure control was maintained in 59% of the intervention group, while only 31% of the control group had blood pressure control. So we are starting to see some of those long-lasting changes. In 2009, another recent study. This was a randomized control trial where clinical pharmacists made drug therapy recommendations to physicians based off of the national guidelines. And so this resulted in an adjusted difference in systolic blood pressure at 6 months of a 12-point difference compared to the control group. And it was noted that blood pressure was at goal in almost 64% of those patients in their intervention group. And there were some long-lasting effects to the intervention because it was noted that even after 18 months of the study, after the study was discontinued, systolic blood pressure was controlled in the intervention group at a goal of 67% of those patients versus only 36% in the control group. And they actually suggested with this study that the long-lasting effects were likely related to the fact that the pharmacist was able to make those medication adjustments that resulted in some persistent blood pressure control. So in 2009, they actually looked at a bunch of studies, and what they were trying to evaluate was the potency of a pharmacist-assisted management of hypertension, and it actually showed a significantly greater likelihood of blood pressure control. And so I kind of want to look at some of the components that were most effective. And so we actually see that when the pharmacist recommended a therapy to a physician, we saw about a 9-point drop in blood pressure. And even just simple patient education provided by the pharmacist was pretty significant at also a 9-point drop in blood pressure. And when just medication adherence was assessed, and that means was the patient taking their medication appropriately, we did see almost an 8-point drop in their blood pressure. And so when we're looking at all of these studies, we see that there's a great amount of studies showing the impact that pharmacists can have in this collaborative care team, especially when it comes to managing a patient's hypertension. And this actually had some implications both in the short term and the long term. And so by having a pharmacist on board in the collaborative care team, we can definitely see a lot of these great effects in helping manage those patients. And as Dr. McVeigh mentioned, we have 1.8 million Alabamians suffering from high blood pressure. If we can help control at least just a fraction of that by being involved in their care, I can imagine how low we can get that 1.8 million with just proper blood pressure control. So now I really want to focus on some of those points that I said about how can the pharmacist actually impact patient care for people with hypertension. And so some of the ways that we can assist in that is, one, we can work with the healthcare provider in designing a medication regimen and also design a monitoring plan that will provide the most benefit to the patient. We can also recommend adjustments to the medication therapy during follow-ups, especially when patients are not at their goal. We can recommend intensifying therapy if necessary, or maybe switching to another class of medications if necessary. And this goes on to my third point, is that optimization of medication regimens for specific patient groups. So as Dr. Maxwell had mentioned during her presentation, there are certain ethnic groups, such as in African Americans, that would benefit from maybe having a calcium channel blocker on board, or those diabetic patients and having an ACE inhibitor on board. And so we can make those types of recommendations to physicians and other healthcare providers to try to optimize that care for that patient. Some other ways that we can help in medication management is just simplifying or managing a complex drug regimen. And so this is mainly trying to decrease what we call pill burden, or having a patient take too many pills. And so what we can recommend is maybe a combination medication. So for instance, we can recommend an ACE inhibitor with a thiazide diuretic as one pill versus 2 pills. We can also maybe recommend a once daily dosing formulation, so they're not having to take the same medication 3 times a day. They can just take it once a day, where it can actually help increase adherence to their medication regimen. Speaking of adherence, the fourth area that we can really help patients is actually performing an adherence assessment with a simple validated questionnaire, and I'll go over this in a little bit. And it's called the Mariski Medication Adherence Scale. And this is going to help assess the patient's adherence to their blood pressure medications, as well as, once we know what is causing their adherence issues, we can then apply some strategies to help increase their adherence to their medications. Another area is in recommending cost-effective medications. So one of the reasons that patients may not take their medications is that it's too expensive. And so what we can do is recommend a lower-cost medication that is just as effective. And that can help reduce some of that burden that the patient may experience when managing their hypertension. Also, we have the knowledge and ability to detect drug interactions that could lead to adverse reactions and or those adherence issues. And so what we can do is then make those recommendations to modify that medication regimen to help reduce some of those side effects that they may experience just because it's interacting with another medication. So another area that I really want to talk about is that medication and disease education counseling. And so when patients come to me, they need to understand or have a basic understanding of the disease to make an informed decision about their medications. And so, like I said, pharmacists are that easily accessible health expert. And we can provide patients with accurate and easy to understand information on hypertension along with other medical conditions. So they're not resorting to going onto Google to find out what a disease is. Instead, we can be that resource for them, and we're pretty more accurate compared to Google sometimes. We can also help. This education is also going to teach patients not only about the disease, but it's also going to help teach them about this associated risk of their health if it's not managed properly. And it's also going to teach them about available treatments and also some of the treatment goals. So knowing that their goal blood pressure would be less than 140/90, or if they're elderly, being less than 150/90. When we educate these patients, it's going to help open up that discussion with them for the rationale of certain medication choices. So once they have that understanding of what this disease is, what their goals are, then we can make that discussion of, okay, well, let's talk about the appropriate treatment for them. And that will allow the patient to be more active in their care, as opposed to someone saying, here, take this medication, it's going to work for you. Instead, they're going to be more inclined to take that medication because they know the reasons why they need to take it and the benefits that they can have from taking that medication. Another area is going to be in medication counseling. Again, pharmacists are your medication experts. We can easily discuss with the patient the appropriate use of their medications, how to administer their medication at home, how to properly store their medication. So this means not storing their medication in the medicine cabinet in the bathroom, storing it in a nice dry place like in their kitchen drawer or something. Also talking to them about the possible side effects of medication, so what to expect, especially when they're first starting that medication. A lot of patients are walking around with high blood pressures and don't even realize they're walking around, but once they get started on the medication, they feel worse. And so that gives them more inclination to stop that medication. If we can educate them that, hey, this is what to expect, they may be more inclined to expect that and understand that, okay, this is a side effect, but it will go away after a certain amount of time. In addition, since the patient will typically see the pharmacist more regularly as compared to some of their healthcare providers, the pharmacist will have more opportunities to follow up with that patient on important aspects, especially when it's evaluating for any side effects, which can also hinder that adherence. And so, again, we could see them more often, maybe every 30 days or every 90 days. We can always ask them, oh, how's that medication working for you? And then that opens up the opportunity for them to discuss any side effects that they might be experiencing, or even open up any other discussion areas like, oh, can I take this over to counter medication with my current medications that I'm taking? So I want to touch on medication adherence for a little bit. It is estimated that poor adherence costs the United States $100 billion each year. And this non-adherence can be either voluntary or involuntary. And so involuntary could include just forgetfulness, but there's also voluntary reasons for non-adherence, and that could be high cost, or it's too complicated of a regimen. They might have a poor quality of life, so they see no reason to be taking that medication, or they just don't understand the disease and don't understand that taking the medication is actually going to help them. And so there are many causes for this non-adherence, so that's why it's important that we should assess why they're not being adherent to their medication. So I want to talk a little bit about the Morisky Medication Adherence Scale. And this is really a simple, validated questionnaire. It's 8 simple questions, and this is actually tailored for hypertension. And each question is going to measure a specific medication taking behavior as opposed to adherence or compliance behavior. And so the patient's score is it will determine if they have a high, moderate, or low adherence. And when actually studying this questionnaire, it was found that there was a correlation between blood pressure control and high scores on the adherence scale, which was actually statistically significant. And there's also a high sensitivity to this scale in detecting non-adherence. And so this is actually, like I said, it's a simple questionnaire that we can ask our patients, and we can determine, are they having adherence issues, and possibly determine why they're having adherence issues. So once we know that the reasons for a patient not being adherent to their medication regimen, that's when the pharmacist or really any other healthcare professional can actually intervene and provide strategies to help improve their adherence, which can then lead to better therapeutic outcomes. And so sometimes we may have to use multiple strategies to try to help improve their adherence, but hey, if it's just one or if it's many, whatever way that we can help this patient take their medication appropriately, the better. So some strategies could include ensuring that patients understand the purpose of their medication. So why are they actually taking this medication? Involving the patient in that decision-making process. Again, like I mentioned, educating that patient on what the disease is, how can it actually affect their health overall, and then that can maybe help them understand why they're taking this medication, and then it can lead to them deciding what medication will be best for them. Also, just simplifying that medication regimen. Again, like I said, if they're having to take multiple tablets each day, maybe switching to an extended release formulation where they're only having to take it once a day. Or if they're having to take 4 pills, why not combining 2 of those pills so now they're only taking 3 tablets? Or there's actually some combination tablets that have 4 medications in it, so they only have to take 1 tablet, and it's usually a once-a-day formulation. Simply creating medication reminders. I cannot count on my hands how many times I've recommended for a patient to set an alarm for themselves to take their medication. So, for instance, I'll have some patients come in and they'll say, oh, I always forget my nighttime medication. Well, I tell them, okay, well, why don't you set an alarm right before, right when you're about to take it, or take it with some sort of activity. So if you're having dinner, take it when you have dinner, or if you're going to bed, take it right before you go to bed. Leave it by your nightstand. So we can make these simple recommendations, which can definitely go a long way, especially when we're trying to control their disease. We can also resolve any adverse drug reactions. So like I said, by educating the patient on what to expect, we can provide strategies on, okay, this is how you should maybe, instead of, if they're going to experience dizziness when they're first put on their medication, recommending that they get up slow, and tell them they might experience dizziness for about a week or so, and after that, you're going to be fine because your body's going to get used to that lowered blood pressure. So just by simply telling the patient what to expect and telling them, hey, this might not be as bad as you think. It might be bad for the first week, but not going to be bad for the weeks after, and you're going to feel much better once you're on the medication. It can really help a patient out. Also, just monitoring and adjusting that drug therapy. Again, by working in that healthcare team, we can make those recommendations that, like, for instance, if they're not having optimal blood pressure control, we can always recommend an intensifying that therapy or adding on another medication that could help get that patient to goal. Some other strategies, again, would be educating the patient on the consequences of non-adherence, telling them, if you're not taking your medication, your blood pressure is going to go extremely high and you'll be at risk for a stroke. Sometimes patients don't realize when they have high blood pressure that can put them at that high risk, and don't understand that a stroke can be life-threatening. They may not realize that. And probably the most important strategy, I feel, is actually being that positive reinforcement. A lot of patients are really going to fare better when they're positively reinforced. So congratulate them if they've taken their medication every day for 1 week, or if they come back to you and they're refilling their medication exactly 30 days from the last fill. Say, hey, I see you're doing really great with filling your medication on time. That's awesome. I want you to keep doing that. They're going to be more inclined with that positive reinforcement to take their medication appropriately. So be that positive reinforcement for them, because a little bit does go a long way for these patients. So another area that we can definitely have an impact is on lifestyle management counseling. And so since, again, we're those easily accessible health professionals, health experts, that we can provide accurate and easy to understand information on how to change their lifestyle around. And so we can definitely provide ways to educate them on the DASH diet and how to effectively reduce their sodium intake. We can also tell them the goals for physical activity, making sure that they're staying active and providing suggestions on how to stay active. We can also help them with weight loss. We can tell them, explain how these lifestyle changes can actually help them lose weight. Some pharmacies actually offer a weight management program, and where I work at the State Wellness Center, I actually help manage a weight management program to try to help patients lose weight, and that can have many benefits all around to not just hypertension, but a whole gamut of chronic disease states. And then we can also explain the current therapies for weight loss. So there are medications that are out there being used, and we can explain the pros and cons of using those medications to help them lose weight. Another area is explaining that with alcohol use, it can have some detrimental effects on their blood pressure. We can also provide them information on smoking cessation and provide strategies to help them successfully quit. And also we can recommend over-the-counter and prescription medications to try to help quit smoking. We can also be that resource to provide appropriate counseling on monitoring their blood pressure at home. We can recommend appropriate devices that the patients can easily use. We can then show them the proper technique, and we can also tell them about recording their numbers. Again, it was mentioned about white coat syndrome. If they record at home, this can help actually improve their care and determine, are they actually hypertensive, or is it only occurring when they're in a doctor's office? And I know when I'm in clinic and I do blood pressure checks, or if I'm counseling on blood pressure monitoring, I usually tell them to record those numbers and bring them to their doctor's office visits, so that the doctor can look at that, assess, and then determine if they really need to go up in therapy. So they're not just having that one snapshot of the doctor's office reading. So, again, highlighting some of the important aspects or the important impact that pharmacists can have on hypertension management. Again, as I noted with all the studies, there was clinically significant benefits in hypertension management when pharmacists were integrated into the healthcare team. We can assist in providing optimal medication management. Again, pharmacists are that easily accessible health experts that we can provide accurate health education as well as medication counseling. So again, we're located on almost every street corner in the United States now. And sometimes we compete on street corners. If you ever see a CVS and Walgreens on the same street corner, that's the competition. We can also help the patients improve their medication adherence, and we can also provide various types of lifestyle management counseling. So with all these aspects to consider, pharmacists have become an integral part of the healthcare team in providing patients with optimal care in hypertension. And so now I'll entertain some questions while I scroll through some of my references that I use for this presentation.
We don't have any questions at this time. So we'll go ahead to our next presenter, Peggy Henson from East Alabama Medical Center. Peggy.
Good afternoon. It's my great pleasure to be here today to have the opportunity to share some information about my particular discipline of nursing and really a passion that I have, and that is of parish nursing. You know, I've been a registered nurse for a lot of years, and I shouldn't even name numbers, but I've almost 42 years, in fact, and have experience in critical care and college health nursing. But I believe I've saved the best of my career for last. I'm so grateful to have the opportunity to give voice to the role of parish nurse in our community. My task today is really divided into three parts. First, I want to begin with describing the practice of parish nursing itself in general. And then next, I'll describe our specific program at East Alabama Medical Center and East Alabama Lanier, and the role that we as parish nurses play in controlling hypertension within our faith communities. And then lastly, I'll describe an example of how we manage hypertension within our community at large, and specifically how we handle it at Darden Wellness Center in Opelika. If I had to define parish nursing in one sentence, I would simply say that a parish nurse is a nurse who intentionally cares for the spirit. We pray with our patients or our clients. The parish nurse program at East Alabama Medical Center has been serving our community now for 16 years. But the discipline of parish nursing is really an old idea with a new twist. Often when people hear the word parish, they might assume that we are describing a nurse that functions in a Roman Catholic or Anglican church or faith community. I'm a parish nurse, for example, at Holy Trinity Episcopal Church in Auburn. And so, in fact, we do refer to our congregation as a parish. But in more recent years, parish nurses have been called faith community nurses, which I suspect more accurately describes where we practice. But let's begin at the beginning. I don't want to get too far into my talk today without talking about the concept of health in general. I want to describe how a parish nurse approaches health. And I'm sure if you've ever thought, and I know you have, about the meaning of the word health. Very often when I talk in public about health and I ask this question, I find that the response given most often centers around physical health. But long ago, the word health actually had a different meaning. The word health originated from the word whole. Parish nurses approach health then from a whole health perspective. We see this whole health model that's on the screen now that we can see that no one part of it is larger than the other. We are truly integrated human beings with physical, emotional, and spiritual needs. The parish nurse addresses the whole health needs of every client. So long ago, it was the religious orders, the deaconesses, that provided care for the infirmed. And during the mid-1970s, a clergyman, hospital chaplain known as Granger Westberg, observed that patients who had their spiritual needs addressed, their whole health needs met, fared better, and they had better outcomes. Granger today is remembered as the father of the parish nurse discipline. His focus was on prevention, whole person care, and the church as a healing community. Specifically then, a parish nurse is a licensed registered nurse with a minimum of 2 years experience as a practicing registered nurse who has completed a Foundations in Faith Community Nursing course. And today there are over 15,000 practicing faith community nurses, both nationally and internationally. So what does a parish nurse do? Parish nurses offer a variety of services within our faith communities based on the individual needs of that congregation. This is discerned. We figure this out through health needs surveys. We currently have 25 parish nurses serving in 26 faith communities in 7 counties surrounding East Alabama Medical Center. Not all parish nurses are compensated for their efforts, but we are very fortunate at East Alabama Lanier to have the support of the administration from the top down. In fact, it was our executive vice president, Laura Grill, who was instrumental in the formation of our program. And there have been 2 coordinators for our program, and I'm the third. The parish nurses at East Alabama are fortunate because we're paid 2 hours a week to be away from our hospital duties, to be in our individual faith communities. And we're found throughout the hospital practicing in a variety of areas. Our parish nurses serve as personal health counselors, health advocates, referral agents, support group leaders, health educators. Within our faith communities, we sponsor blood pressure screenings, offer health fairs, educational programs. We teach the American Heart Saver, CPR, and first aid. We promote whole health through bulletin boards, newsletters, websites, and educational programs. We do not replace community health services. We're simply there to connect the dots and to enhance those resources. No 2 parish nurse ministries under the East Alabama Medical Center umbrella are exactly alike. But I believe one of our greatest strengths of our program is the diverse army of East Alabama healthcare resources that we have available to each and every one of the parish nurses. We have pharmacists, we have social workers, we have nutritionists, diabetes educators, collaborative relationships also we have with many community resources, like, for instance, Lee Russell Council of Governments, and the Area Agency on Aging, community food pantries, housing authorities, the Auburn University School of Nursing, and the Auburn University School of Pharmacy, United Way, just to name a few. So the hospital actually enters into a legal contract or covenant with the participating faith community and agrees to send the registered nurse for training at a nationally recognized Foundations in Faith Community Nursing course, and also supports her weekly within the church. In return, the church agrees to support this ministry and by forming a health cabinet and helping to discern the programming for the community. Recently, I heard a speaker when they were describing the universal H that you see that signifies a hospital is nearby. And she stated that the symbol H actually really stands for much more when we manage chronic illness such as hypertension. It has come to mean health care within the community in general, not just the hospital that's involved in health care. And I believe that our East Alabama parish nurse program is really a testimony to that concept. Specifically, the parish nurse is in a unique position in the congregation to develop a trusted relationship with the hypertensive or potentially hypertensive client. Introducing lifestyle modifications, our partnership begins with a simple conversation. Introducing lifestyle modifications to prevent and manage hypertension in a timely manner. Whether it is through broad screenings or face-to-face educational sessions, the parish nurse is available to provide confidential, and everything that we do is absolutely confidential, individual monitoring, education through self-monitoring, regarding self-monitoring, weight management, physical activity, smoking cessation, talking about dietary approaches to stop hypertension, and in eating ways. And we include ways to reduce sodium intake and limit alcohol consumption. I believe that we are also uniquely positioned to offer medication reviews as well, ensuring clients' understanding and compliance with all medications, and we refer as needed. And we've had approximately 8,000 contacts within our congregations each year. That's a pretty large number when you think about it, and have had innumerable successful interventions that I believe have made real differences in the lives of our clients. One example that I could give you is a parish nurse was called to visit one of her parishioners, one of her congregation, and they just said he's not feeling well. She met him at the mailbox, and he was literally hugging the mailbox. Well, by the time they walked from the mailbox back into the house, she had figured out that he had gone to numerous physicians, had a little polypharmacy going on, and was on way too many antihypertensives. As I mentioned, the parish nurses play an active role in healthcare within the community. And one such example of how our work would be at Darden Wellness Center in Opelika. Dr. John Wesley Darden was the first African American physician in our area. He was a beloved community servant who came to Opelika at the turn of the last century, and he provided much needed health care for the underserved in our area. And he met and married a woman by the name of Maud Jean Logan from Montgomery, and together they made Opelika their home and built a wonderful home on Auburn Street in Opelika. Dr. Darden's brother, J.B., a pharmacist, followed him to Opelika soon after he arrived, and together they built one of the first drugstores in the area. As the only black doctor within a 30-mile radius in an area of horse and buggy, Dr. Darden's workdays often lasted 18 hours. He, again, as I have said, was a beloved community servant, and in fact, in 1951, 2 years after he did die, an Opelika High School was named bearing his name. And throughout the years, Dr. Darden continued to operate this drugstore. He operated in an infirmary for African Americans where he performed surgeries. He treated inmates at the Lee County Jail, and he was an active member of in one of the local churches. Both he and Mrs. Darden were cherished members of our community and often entertained prominent visitors like Booker T. Washington, George Washington Carver, A.G. Gaston, and at their home that's pictured here on Auburn Street. But by the early 2000s, the home, vacant and in ruins, was scheduled for demolition. The community Dr. Darden loved so much, numerous Darden High alumni, representatives from the city of Opelika, Auburn University, East Alabama Medical Center, and just civic-minded people interceded, preventing the demolition and restored it to its original state. What's the expression? It takes a village, right? Well, as we've heard over and over again here, it was collaborative relationships that restored Dr. Darden's house to its original beauty, and these relationships continue to this day. By 2006, after a health needs survey of the local area residents around the Darden house, the parish nurses around the area, the earliest programming began at this wellness center. The parish nurses, this is a collaborative effort always, the parish nurses, the Auburn University School of Nursing, and the Darden Foundation partner now each Wednesday morning and provide free health education and screenings from 9 until 12. And just as in our faith communities, the parish nurses serve at Darden as both health educator and referral agents. The Auburn University student nurses assist with the screenings. And I'd like to take a few minutes just to spend my last few minutes speaking specifically about how a parish nurse at Darden might help the hypertensive client manage his or her blood pressure. We always, on visits, obtain a thorough health history. This is so important, assessing body, mind, and spirit. And we actually keep written physical charts on our patients that are confidential and are property of the hospital, in fact. And we always include all medications, all physicians. It's really important to have a thorough medical and surgical history, allergies, etc. And as we've mentioned and talked about so much here today, we always include a blood pressure reading. And this is an important time, and it's an intimate time where we can really demonstrate to our clients what the proper way is to take a blood pressure and the meaning of what the numbers mean and so on, and offer simple explanations that can be understood. We talk about weight and the importance of maintaining a normal body weight. We can do blood glucoses as well. We talk about healthy eating. We utilize food models and that demonstrate portion control and how to read food labels. We discuss a DASH eating plan, a diet that's rich in fruits, vegetables. We all know what the DASH plan is. And to discuss lowering sodium intake. And this is so important. Just taking a little history and having a little conversation to discern what people are eating is sometimes eye-opening. Further, we talk about physical activity and the importance of having physical activity. We can talk one-on-one about stress. Stress is very powerful. We mentioned that earlier. We talk about limiting alcohol consumption and smoking cessation. We can point our clients in the direction for help with all of these things. And we talk about medications, very important, obtaining a complete medication list. And also to assess the understanding of the client has of the medication, the dosage, why they're taking the medicine. We talked about that, disease, understanding of their disease. We reevaluate the medication list every visit when clients come. We document the source of the medication list and the pharmacy that they use, because that sometimes brings to light how many pharmacies they are in fact using. We encourage compliance. If nothing else, we're cheerleaders. I believe we're pretty good cheerleaders. And looking ahead, I just wanted to share a couple future goals. We continue to improve communications. We're trying to improve communications among the parish nurses themselves by reviewing standardized protocols for blood pressure and diabetes management. Very important. And we're looking at Darden Wellness Center and trying to develop a transitional care plan utilizing the parish nurses. You probably know that care transitions refers to the movement of patients between healthcare practitioners and settings as their condition and care needs change during the course of a chronic illness such as hypertension. Many readmissions to the hospital can be related to lack of resources, issues with health literacy, and managing complex medication regimes, transportation issues, lack of caregiver support, and we hope that we can utilize the parish nurses at Darden to do what we do best, and that is connect the dots. And Dr. Darden's legacy lives on more than 100 years today after he first arrived in Opelika. And thank you so much.
Thank you for this presentation. We have received 2 questions earlier. Ken, would you like to address those questions?
Many of the items on the list that contribute to high blood pressure are easily controllable, such as salt intake, exercise, and diet. What would you recommend for a patient that thinks stress is their main cause of elevated blood pressure? And that can be very hard to control in the fast-paced world we live in. They wanted to know if you had any suggestions.
Well, the one thing I would say is to identify the triggers, what causes them stress, and to really have a conversation with folks about what is actually causing stress. And we all know that there are different ways that we can reduce stress, and exercise might be one of them, meditation, breathing exercises, walking, and, prayer, addressing their spiritual needs as well, might be something that would be very helpful.
I would agree with what Peggy was saying. Identifying what your stressful triggers are. Sometimes you can't avoid those stressful triggers, so coming up with mechanisms, if it's just stepping away from the office for 1 minute, relaxation type breathing. I personally have a book in my office, 100 Quick Ways to Reduce Stress. One of the easiest things is take 10 deep breaths and count for about 10 seconds. You'd be surprised how much that lowers your blood pressure, lowers your heart rate. Meditation, as she mentioned, yoga, exercise. We have to learn how to better manage our stress. And in this day and age, it's always present. It's in the smartphone. You can't go anywhere and detach. So sometimes it's detaching and getting patients to recognize or measure their blood pressure when they're in non-stressful situations sometimes helps them to see what their sources of stress are.
Thank you for those answers. And is there another question?
Another question is, how do you motivate patients to home monitor their blood pressure and to instill the importance of monitoring your blood pressure at home?
So in my clinic, I'm a family physician, and so within the medical arena, we're the touchy-feely doctors. We want to know what's going on, and we really do, because sometimes the best motivation is that grandchild who has a birthday coming up that they want to be a part of. It can be, well, my son or daughter needs my help. So sometimes it's not the patient that's the motivation. It's something in their environment that's more important to them. The other thing is sometimes it's a good way to say, well, prove to me that you don't need medicine. Check your blood pressure every day for 2 weeks, bring a log, and let's sit back down. And so sometimes it really does work. Even with white coat hypertension. At my first job, I had a patient. Her blood pressure was 160/90 every time she came in. I was new to the practice, and she knew the drill. When she first met me, she said, my blood pressure is high. When you look back, it's going to be high. So I've already brought in my log to show you that my blood pressures are normal at home. And so that's a useful tool. Sometimes it helps the patient track what's going on with their body.
In addition to that, when I see my patients over at the State Wellness Center, I actually reiterate the fact that this can actually help their doctor by monitoring at home. And I usually try to stress that point that you're going to have a high blood pressure reading. If you have it with me, you're going to have it with your doctor. And so monitor at home, and I express what type of goals that they're looking for. And if they're seeing those consistent readings being higher, then I tell them, then go to your doctor's office and show them these readings, because this can tell your doctor whether or not they need to move up or down on their medication. So I really put that point onto there, that this is going to help them better control their hypertension by having that discussion with their doctor.
Are there any other questions at this time?
I think we've got one more question. The question is, what percentage of patients that have hypertension under control because of they faithfully practice their DASH diet? Have y'all seen patients that do practice these lifestyle changes? Mm-hmm. Is it beneficial?
It's absolutely beneficial. In the patient who, let's say, has a strong family history, they're fairly active, and they've done well, maybe up until 50 or so, to ward off this genetic component. They're usually very motivated to avoid medication. And so when they implement the DASH diet, they implement the physical activity, they bring in their logs, and you very well see that they don't need a prescription medication at that point. Even on patients who have difficult to control hypertension, when they make the changes, and in my practice, we tend to implement one thing at a time. If it's the salt, let's work on the salt for a couple of months, because that's a hard relationship to end. And so even patients who may be on 3 or 4 medicines, if they would implement, we can get them down to 2 medications sometimes. So it really does work.
All right. Thank you for those questions. We really appreciate that. And Dr. Maxwell, the blood pressure toolkit.
Okay. So we're quickly going to review some of the tools that are available to you on the internet through the Department of Public Health's website. There's information about the Million Heart Study. This is our project. This is an initiative that was started in 2011. It's nationwide. It looks to pair public entities and private entities to help decrease the number of strokes that we see on a national basis. There are a lot of caveats to this program. There are lots of ways that people can be involved. If you're interested in learning more and seeing what you can do in your community, plenty of information on the website to give you specifics as to how to get involved. Here's another tool from the toolkit. It talks about the ABCs of heart disease, stroke, and diabetes. Appropriate aspirin therapy, looking at your A1C, blood pressure treatment and control is part of this. Other components are cholesterol and smoking cessation. It's quick, it's easy to read, it's fairly non-complex, so it's a good handout that's available online if you want to use it in your church or at a community health fair. We mentioned briefly the blood pressure task force work group, and the task force worked to develop the algorithm for Alabama. There are periodic conference calls to reassess and see what else needs to be done to address hypertension in our state. This toolkit is designed to be used by anyone. The information is accessible and it's very user-friendly and easy for patients to understand. Some of these we're going to go through. This is a nice handout. It talks about working towards blood pressure control. It gives, you've all probably heard these commercials about FAST and what to do with early stroke symptoms. So this one covers several different activities or tools that you can use as far as it relates to cardiovascular disease. This one is another nice one specifically about high blood pressure. You'll see that this number has the 120/80, which for a long time was where we were taught blood pressure needed to be. And again, that's a conversation you need to have with your healthcare provider, because for some patients we do want to push towards that goal. It talks about the different risk factors associated with elevated blood pressure and the different stages of hypertension. This is another useful one about choosing a home blood pressure monitor. Luckily, most of the monitors are validated before they come into the store, so you can see this was validated using X, Y, and Z. The biggest thing is the cuff size. I think is very important. And this talks about how you assess cuff size and helps you to buy the appropriate monitor. This is another useful tool. It just reiterates which things can affect your blood pressure. So having a full bladder can increase your blood pressure. If the cuff size is not correct, it will have an effect. If you're not in the proper seated position, you'll get an inaccurate blood pressure reading. So here's another one that's helpful. It says, what can I do? And it talks about the lifestyle modifications. What's very nice about this is on the right side, it tells you how many points you can lower your blood pressure with each modification. And sometimes that's very motivating for patients to see. If their blood pressure is only mildly elevated at 148/85, then they know that if I do one of these things, I can get my blood pressure to go. This is one of my favorites. I use this one in my clinic because it is just so relevant. It really makes people understand that, oh, I don't eat a high salt diet, but you eat a lot of prepackaged foods, you eat a lot of TV dinners, even the smart ones and the lean cuisines. So this one has been very useful because it's eye-grabbing, it's colorful, and it goes over the hidden salt in our diet. So this one I personally use a lot in my clinic to help patients see, yeah, you do eat a lot of salt, even though you don't add salt at the table. This is another one, the Salty 6. It talks about 6 of the most common places that we get an excess amount of salt. And one of them that sometimes people don't think about are the cold cuts that you put on sandwiches and your canned soups. Very high in sodium. So the DASH eating plan, we've talked about that a good bit. It's a diet that's low in sodium, high in fruits and vegetables. It actually works to increase your potassium intake in a roundabout way. And by naturally increasing your potassium intake, you lower your blood pressure. What happens a lot with these diets is, well, how do I apply it? What do I do? I know what that means. And so there are some very nice handouts online that suggest meal plans, recipes, things that patients can actually take home and incorporate. This is just more of the dash. And this is what I was mentioning, a sample dash menu. A lot of times patients will say, well, what can I eat? You tell me I can't eat X, Y, and Z. Well, what can I have? And so this just gives them a sample day and allows them to see, you know, what combinations of foods are useful for them. This one is helpful because it talks about portion size. It helps you estimate what so many ounces of meat looks like. If you say the size of a deck of playing cards, the size of a CD. So this makes it relevant to patients. You may say only have so many ounces of this. Well, most people don't have time to sit down and measure every time they eat a meal. So these are just some quick tools that have been very helpful because people can relate to those different objects. Again, also on the website are examples of recipes that would be low sodium. This is a program for clinicians, as a part of the Million Hearts program. And then again, this just is the actual tool for developing an algorithm. What's nice about this is you can, I think, save this format or either copy it and you just put in what you want in each box. The action steps are already filled in for you. So that's available online for anyone to utilize as well. Again, this is a piece talking about getting to control. It's one thing to let people know, to identify hypertension in patients, but we need to go a step further. We can start medication, but as everyone has said, you need to reassess. If you've been on these medicines for over a year and every time you come in your blood pressure is high, then something needs to happen. Something needs to be done. And that's it.
All right, we want to do we have any additional questions that have come in?
We hadn't received any additional questions.
Well, we want to all our viewers to know that you are in very good company. The fact that we have had pre-registration of between 300 and 400 people, and the good news is, and on the screen they will show you our on-demand website. Within 2 days, this program is going to be up, and for the upcoming year, nurses will be able to get continuing education credits by taking it at a later date. For social workers, they can take it for up to 2 years. So as we mentioned earlier when we started, be sure to tell other professionals that need continuing education credits that this would be a very convenient way for them to get it. So we want to thank our presenters today. We want to thank all our viewers, and the health department is more than pleased to put on this kind of training program. So thank you so much and have a pleasant afternoon.